Really happy to welcome Dr. Saifi, who's going to give us a talk on how to tell the difference between a pathologic fracture and a normal insufficiency fracture, because that's a very common clinical scenario.
I appreciate it, Dr. Pullman. I appreciate the opportunity to present. As you mentioned, I'll be discussing separating insufficiency fractures from neoplastic fractures. These are my disclosures. So, um, I think this challenge, while many cases of insufficiency fractures determining whether they are, metabolic bone disease versus, say, obviously pathologic tumors. That's pretty clear. But the issue, I think, for many of us is just the sheer volume. And so, if we look at vertebral fractures per year in the US, there's 1.5 million. The majority of those are osteoporotic, but obviously there is a sizable portion of neoplastic tumors. And we can see that the rate of vertebral fractures in this study really begins to become exponential after age 70. And so, when you have these patients who are at that age and you see a lot of compression fractures, it is, certainly possible to attribute a vertebral fracture to a compression fracture when in fact it's pathologic. And even compression fractures have a significant 1-year mortality, but obviously a pathologic fracture is higher. So in terms of etiologies, as I kind of touched upon, insufficiency fractures really result from minimal trauma composed of metabolic bone disease, obviously osteoporosis being the most significant, but steroid-induced fractures are significant, as well as renal osteodystrophy. Pathologic fractures primarily come from breast in the spine, breast, lung, and prostate, multiple myeloma, as well as, to much lesser extent, primary bone tumors. So in terms of clinical signs, that's going to be the first piece of the puzzle in terms of our clinical decision-making. Insufficiency fractures with low back pain in this Cochrane review of 17 studies found that 4 factors were the greatest: corticosteroid use, age over 70, recent fall, and a contusion or an abrasion on presentation. Whereas for pathological fractures, the signs with low back pain include night pain, which had a likelihood ratio of 2.3, weight loss greater than 10%, which was 3.1, and a prior history of cancer, which had the most significant correlation to a pathologic fracture. In terms of imaging hallmarks, there's a lot that could be said about this, but these are kind of just the basics here. Obviously, as we know, in compression fractures and insufficiency fractures, we'll have anterior wedging, no bony destruction. The pedicles are preserved. The T1 sequence will have preserved fatty bone marrow. And obviously, we won't see any epidural mass. One thing we will often see is this fluid sign, which is represented in the image on the MRI where my cursor is. And you can see this fluid, and that is typical of a compression fracture and not a pathologic fracture. In terms of pathologic fractures, the classic textbook sign is the winking owl sign, which is illustrated in that radiograph right below with the circles, and you can see where the arrow is. That there's no pedicle apparent on that AP X-ray, indicative of a destructive bony lesion. Fractures with bony destruction on the CT scan, as you can see in that middle CT image, extension into the pedicle or posterior elements is commonly a sign of a pathologic fracture. And then more subtle but very important finding is that if there's convex bulging of the posterior vertebral cortex, but not necessarily retropulsion, and we see that on MRI or CT, that can be very much indicative of a pathologic fracture. And then, of course, any epidural or paraspinal mass, or if the patient has obviously other vertebral metastases, those would be clear signs of a pathologic fracture. In terms of PET-CT, this is a little bit newer, but there's been numerous studies done, and I personally have used this when it's unclear or I'm in that kind of situation where it's a little bit gray. And so there are studies that have found that an SUV max greater than 4.25 is associated with it. Now, obviously, there's a bell curve to that, but that is a threshold that I often use. And then this can be, as I mentioned, very helpful PET-CT in patients who have equivocal findings on other imaging. This study had looked at the sensitivity and specificity in terms of different elements on imaging, including epidural mass formation, convex posterior cortex, as I mentioned before, pedicle enhancement, or a combination of all three. And so that can be helpful findings. The sensitivity in that study for the PET-CT was 100%. As we just discussed in the last case, biopsy is critical in any spine tumor case to determine really the diagnosis. CT-guided for biopsy, as we discussed before, is the go-to for biopsy. And typically what we use, particularly in these situations, as they may not be pathologic tumors, and it's more for ruling out. But open surgical biopsy is, in some instances, can be helpful, particularly if the patient has an acute neurologic deficit and you don't have the ability or luxury of having a CT-guided biopsy. So management algorithm overall, as I mentioned, obviously history and physical. We discussed the kind of pertinent clinical findings for both insufficiency fractures as well as pathologic fractures. The imaging, again, the findings on MRI, X-ray, and CT that delineate between the two, and then in some cases going to PET-CT with the threshold of 4.25. And then really looking and seeing if that imaging suggests it. And of course, if it's equivocal, then we proceed to the PET-CT. And then lastly, biopsy. So in conclusion, timely distinction is the crucial aspect of this. Obviously, if it is pathologic, we want to treat it, particularly if it is, in these situations, these patients could be potentially undiagnosed. And so early intervention is critical, not just from a spine standpoint, but from an overall oncologic standpoint. Recognizing the red flags early and confirming the diagnosis with imaging is critical. As I mentioned, PET-CT can help in equivocal cases. And if in doubt, always biopsy. I think sometimes I find myself not wanting to do a biopsy because I don't want to inconvenience a patient who I think is likely has a compression fracture. But it's kind of like appendectomies. If you never take out a normal one, then you're probably missing some. So I think it's always a good idea to err on the side of caution with biopsy. So I'm going to move on to a case. This is not my case, but from someone else. But I think it illustrates this point very nicely about pathologic versus osteoporotic compression fractures. So this was a 78-year-old gentleman who initially presented with back pain and some left leg pain, or initially back pain, had a kyphoplasty done at an outside institution, actually had a 3/4 left-sided foraminotomy done, which you can see some of that resection there. On the left side due to left lower extremity radiculopathy, was then transferred 4 months later, developed left lower extremity weakness, was then transferred to another facility. And you can actually see this is 4 months prior to the presentation where the arrows are. And you can see that there is some extension into the left pedicle. So this should make one suspicious for that this is pathologic and not a compression fracture. And then 4 to 6 months later, this has clearly progressed. and has become expanded into all the posterior elements and on the left side. The patient had a laminectomy done upon presentation and a biopsy done at that time. Also had a PET CT scan done and clearly see the left lung as well as the liver both having clear uptake of this lesion. It turned out to be a squamous cell of the left lobe and had metastasized, excuse me, to both the spine and the liver. So just a cautionary tale, I think, for this kind of situation.
Yeah, I want to just like emphasize, Comron, that point you made about the pedicle involvement. If you think about it, an insufficiency fracture, I mean, the pedicle is the strongest bone in the vertebral body. The bone never fails at the pedicle, at least typically. So if you have signal in the pedicle, you have to ask the question, is there a neoplastic process? So I think that's a super important factor.
Yeah,
Does the
absolutely.
panel have any comments on this case or the topic in general?
I think you make a really good point. I mean, the entry into the pedicle is alarming and just erring on the side of caution, just like we talked about before, repeat biopsies can be very um, illustrative. And I've seen mycobacterial infections do that as well as pathologic from neoplasm. So just being persistent, being detail oriented and repeating biopsies and like Larry said before, not really rushing into a surgical solution before you have complete understanding is really critical.
Something that I've seen our radiologists do more and more frequently is sort of like getting these MR perfusion images. Um, like I said, I'm not personally familiar with the level of evidence supporting that, but I do think that they seem to be making more and more calls of like whether this is an oncologic lesion versus a degenerative thing or like an atypical hemangioma based off of MR perfusion studies.
So I think opportunistically biopsying, if you're ever in a kyphoplasty situation, even if you're sure it's an insufficiency fracture, I send tissue every time. There's no separate code for biopsy in that case, so you're not going to get anything out of it other than self gratification and confidence and relationship building with your patient to be able to tell them you were thinking outside the box.